Assalamu alaikum and a very good afternoon to all our participants. Welcome to the third session of our COVINAR 2 series, Update and Treatment in Management of COVID-19 Patients. Thank you very much for filling out the pre and post-test forms along with the session evaluation. Don't forget to do that today as well. You have already filled out the pre-tests. We will be sending out the post-test at the end of the session and also the session evaluation forms. Today we've got presentations based on two systemic manifestations and their treatment of COVID, and we've got two excellent speakers. Our first speaker is Dr. Adnan Jabbar. Dr. Adnan is a graduate of Dow Medical College and currently is the section head of medical oncology here at AU. Dr. Adnan has done his residency and fellowship from US, and during his career he's received numerous awards and grants, and he serves on the board of various committees in Pakistan and has several publications and poster presentations to his credit. Today, Dr. Adnan is going to talk on updates in treatment of cancer patients with COVID.
Thank you very much. Assalamu alaikum, and thank you for joining us this afternoon. It's wonderful to be back on the second series of updates in the treatment of cancer patients. Here are my disclosures. Today, what I am going to go through is give you a little overview of cancer management during the COVID-19 pandemic. I'm going to show you some data of the AKU cancer patients with COVID and also answer your queries after the end of the session. We all know the impact of corona on the world globally. These are updates in terms of what was the impact throughout the world. On 12th September, we had more than 28 million confirmed cases throughout the world and almost 900,000 deaths. When you talk about Pakistan, which is the sixth largest population, we have almost 300,000 confirmed cases and almost more than 6,000 deaths. When it comes down to mortality related to COVID, we all know this data. This was by Liang. It was a good WHO China joint mission update where we know that the overall mortality related to COVID is 3.8%. But having certain comorbidities certainly change your risk of mortality, with cardiovascular disease leading the entire spectrum, 13.2% as compared to diabetes, 9.2%. And if you look at cancer is somewhere around 7.6%, which is very high in terms of compared to some of the other cofactors. If you look at patients who are healthy, mortality is 1.4%. That was the number that was being floated when initially COVID was coming up. The risk of invasive ventilation also goes up when we have patients with cancer. It is twice as that of someone who is without cancer, with a hazard ratio of 3.56%. The severity and complication goes up in patients who are infected with this disease. According to a review of this meta-analysis, Wang et al. Identified 4 studies where, according to this meta-analysis, the odd ratio of complications in patients with cancer was 2.29%. The incidence of COVID in patients with malignancy, according to this report, which had 1,500 patients with cancer, and this data is again from Wuhan, China, was somewhere around 0.79% as compared to 0.37%. And 5 of these patients were on treatment at the time of admission. When it comes down to prevalence, there are 2 reviews which are available. These reviews looked at 11 studies which estimated the prevalence of somewhere around 2%, and another 10 studies showed up to 1%. And when you look at, based on the histological subtypes, whether it is breast cancer, lung cancer, or the type of therapy, there was no added significance in terms of the type or subpopulation of the patient. We're going to talk about cancer management. You all know that, and we have talked about this in our first seminar as well, that the approach to our cancer patients is a tiered approach. According to the Cancer Care Ontario Huntsman Cancer Institute and the magnitude of clinical benefit scale, these patients were prioritized into three different categories: the low priority category, a medium priority category, and a high priority category. As one would imagine, low priority were patients where if you delay their cancer management, it would not have any effect on their survival. Hence, delaying treatment or changing it into a different type would not affect their quality of life or overall survival. In your medium priority, you can delay treatment, but not for too long, because any delay more than 6 weeks would end up resulting in a detrimental effect on their overall survival. Hence, these were the patients who would be categorized into a medium priority. And then you have your high priority patients in which immediate treatment is required because any delay in treatment can have a detrimental effect on their overall survival, on their quality of life, and basically on their clinical outcome. If I know this is a little busy slide, but I'm going to help you and go through it. In your low priority would be your cases like someone who has bone metastasis, so where a delay in their treatment for skeletal related events would not be a priority, and these kind of treatments can always be delayed. Patients, their palliative care, their treatments, of course you don't want them to be in pain, but these are the ones where a delay can be okay, where we'll talk about it. Telecommunication would be useful in treating these. But if you come to your high risk, high priority cases, these would be the patients with leukemias, these will be the cases with aggressive lymphomas, where you can technically cannot delay their treatment. Patient who has cord compression, where 24 to 48 hours delay in management can have prolonged weakness in these patients. Hence, these are the patients where one would not delay treatment. So we went ahead and we prioritized patients according to this, and then we treated our patients based on these assumptions, because in oncology, we never went through a pandemic, at least in my lifetime or some of my teachers' lifetime. What we just talked about, I'm going to give you an example by going more site specific. So here I'm talking about the breast cancer consortium recommendations for someone who had early stage invasive breast cancer. Here management was adapted for newly diagnosed patients according to the local conditions, like people in an area where there was a very high incidence of COVID, where patients were more and more coming positive with COVID. Of course, the management had to be taken or had to be treated according to that local site or local healthcare place, facilities that were available. Neoadjuvant therapy could be delayed because in patients who are hormone receptor positive, we all know you can use endocrine therapy, and one can delay surgeries up to 6 months, where you can continuously, regularly monitor them for progressive disease. Patient with early stage disease can also be monitored, and you can delay treatment, especially in luminal A type where endocrine therapy can be used. However, patients with triple negative breast cancer, chemotherapy is required. Any delay in treatment can not only result in upstaging of their, malignancy, but also can have detrimental effect in their overall survival. One can modify their doses in terms of, instead of giving dose DINs, one can give them 3 weekly, but certainly one can not delay treatment in a triple negative patients. We can certainly treat them with modifying them and giving them single agents or giving them support of your GCSF, so that patients cannot become neutropenic. Similarly, for stage 1 HER2 positive, you can have different options like TDM as opposed to chemotherapy with trastuzumab, because we know that this is going to have less effect as opposed to if you give chemotherapy. For advanced stage disease, once again, you can adjust the dose, you can defer routine staging scan if the patient does not have any clinical progressive disease, or you can have delaying treatment, because sometimes at second line, third line, the benefit is not as that much as opposed to the detrimental effect that one would expect from having COVID in these immunocompromised patients. So once again, for your ER-positive patients, one can put them on endocrine therapy and delay CDK4 inhibitors because we know that their major side effects is neutropenia, and these were the assumptions with which we proceeded. For HER2 positive, again, we made a change in their dosing, and also people who had completed their 6 months of treatment, one can, technically reduce their maintenance dose and call them less frequently. What about the impact of COVID-19 on cancer care provision? When COVID struck, throughout the world, how AKU changed their cancer care was some of these measures that we took. We separated our care pathways. Patients who were COVID positive were dealt with differently as opposed to patients who were COVID negative. They were referred and they were admitted in a separate area which was only for COVID patients, thereby limiting patients' exposure to this infection. We know that we had an immunocompromised patient population, so we did not admit any patients in those areas, and anyone who was even a suspect of COVID, we were very quick in transferring them into those areas which were only for COVID patients. We triage patients at our entry points. So you must have seen our desk at daycare centers. When patients were coming to clinics, we triaged patients over there. These patients were triaged again once they were registered for clinic visits so that we may maximize pickup of those patients who had any risk of exposures. We also limited patients' direct admissions. We did not admit patients directly. We admitted patients through ER so that any patients who were symptomatic, had any travel history or any risk of being infected with COVID, thus would not be missed when patients were being admitted. Telemedicine was the key for our providing healthcare, and I'm going to talk a little bit more about it. Staff with signs and symptoms of COVID were isolated. They were swabbed before they would return, and there was a mandatory isolation before they could come back and take care of our immunocompromised patients. Swab test was also being performed for any patient who was being started on chemotherapy, especially if these were new patients who were being started. We had a very low threshold for COVID tests in patients who had any symptoms like fever, anyone who had diarrhea, or anyone who had body ache or malaise. We had a very low threshold in testing these patients because we knew that the impact of them being on chemotherapy and being COVID positive would be detrimental. We isolated our healthcare workers according to the risk profiling. So when we found out that our patients who were admitted, and for instance, they turned out to be positive, we did a thorough checkup for our healthcare workers, whether they were wearing proper PPEs, whether they had N95, face masks, and depending upon their exposure risk, our employee health would then send them or give them recommendations which were according to their risk category. Also post-vacation patients, because now we knew that COVID is not something that would be there for 1 month, 2 months. Our healthcare providers needed time off, but we were very vigilant in terms of when they were coming back to make sure that they had 7 days isolation period before they could come back and return to work. Telemedicine was the key for us. We had our clinical visits and consultations where initial patients were screened and their detailed history was taken through telemedicine. Their follow-up visits were through tele. Their clinical trial visits, patients were also seen through tele. Genetic counseling, survivorships. The evaluations for wounds, we were using Zoom to do that so that our patients have less and less exposure coming to the facility. Palliative care were managed through tele as opposed to supportive care, because normally we would do our support groups and we would do our cancer survivor days, but because of the pandemic, we were not able to do it. Hence, everything went online. And patient education and self-management, like tumor boards, are very important in patient care, and hence everything became Zoom and telemedicine. So the steps that we did was we identified phones. We got, cordless phones, we got speaker phones, and we did telehealth. And it was very important for our clinicians and allied healthcare staff to get used to do telemedicine because it was different. It was very different seeing a patient via, on phone as opposed to even the patients did not at first were at ease talking on telephone. So we had to train the patients as well and their, care providers that this is okay, this is safe for them. So the physicians needed to be taught, the nurses needed to be taught, and how to document are these. People would talk on telephone and not document. We started documenting them on via tele. As I said, we had to train our clinicians, our light healthcare workers for this kind of communications, and also how to book an appointment, how to make your payments. There was a huge learning curve for us. And as you can see, in March is when we went in, there were strict isolations. We were able to see our patients, and all of a sudden, we started almost, 1/4 of our patients became tele. Whether this was medical oncology, whether this was hematology, pediatrics, all of a sudden in April, we started doing telehealth. Providing online consultations for new patients, old patients. And at the end of the day, in August, we have done almost 10,000 consultations. And as a result, if you look at our daycare, our chemotherapy did not stop. Where we were seeing almost 1,400 patients, we were seeing almost 1,100 patients. Of course, patients who did not require Zometa, we delayed them, and hence we saw a drop in their numbers, because then we changed them from weekly to 3 weekly, and we were able to maintain our patients' treatment and without affecting their outcome. This is a very good, manuscript that was done by UK Corona Cancer Monitoring Project. Here, what they looked at was prospective observational study on patients with active cancer treatment and with, COVID, and what was the outcome. They were predominantly, these were almost 800 patients there in their registry, where mostly these patients were male 56% and female 44%, and mortality was higher also once again in male patients as compared to female. Again, the mean age was 69, and if you look at comorbidities, the typical ones that we were seeing with cardiovascular 14%, followed by diabetes and hypertension. If you look at the cancer types, they looked at all cancer types, but the ones which were predominant were digestive disorders with 19% and breast 13%, and they looked at all stage of cancers. Mostly they were almost 43% were metastatic, and then you have primary tumors. What they looked at was these almost 35% of these patients were on chemotherapy. They got hormonal therapy, radiotherapy, surgeries, and then they also categorized them based on whether they had mild symptoms. 52% were mild, and almost 22%, or I would say 40%, was severe to critical. And if you look at the patients who died, it was mostly the patients with critical symptoms who died most. And also the ones who survived were the ones who had mild symptoms. But if you look to your right, amongst all patients, the patients who did get chemotherapy, as shown over here, not all of them had mortality. So patients who had received chemotherapy within 4 weeks of developing COVID, chemotherapy did not have any detrimental effect in terms of their outcome of mortality. Patients with no chemotherapy also had a significant proportion and contribution in the 28% of patients who died. So, as I said, chemotherapy, none, mild, critical, intensive care unit was almost, 7%. And if you look at the odds of death based on the age was significant. Based on comorbidities, it was significant. Based on cancer type, it was not significant. None of the malignancies, whether it was head and neck, breast, digestives, none of them met the significance. So hence, the cancer type, or whether it was metastatic, localized, or whether they were on treatment, none of them had any effect on the odds of death based on the treatment. What did affect, once again, in addition to age and comorbidities, was the severity of COVID. The ones who had more severe COVID were the ones who were more affected in terms of their outcome. So hence, what this study told us that we were very careful in terms of chemotherapy, but there was mortality was not driven by cytotoxic chemotherapy, but it was driven by the age, sex, comorbidities. None of the other treatment modalities had any significance. What you see here is data from AKU cancer patients. We had almost 50 patients that we saw. Again, if you look at it, the proportion is very much similar, 60 versus 40. Comorbidities similar. The distribution of cancers, again, solids was 66% with 34%, and GI being predominant and breast. And people who required active cancer treatment or who were on active cancer treatment was 70%, and with supportive care, with similar symptoms, respiratory symptoms as the main presentation, along with, if you look at the outcomes, once again, it is the same what you saw in the international data. Most of them, for us, the ones 62% had hospitalizations, but 65% of them recovered, and death was in 35% of them. Most of them got symptomatic treatment, and then we have a quite distribution in terms of what treatment did they get. But this data is very similar to what we saw in the UK. So is there a need to modify cancer treatment? Certainly interrupt your treatment. It is strongly recommended when you have COVID. However, based on recommendations, unless the patient becomes negative, you should delay your therapy. There is no consensus in terms when exactly, but patient has to be asymptomatic and COVID negative in order to do so. Your decision to modify and withhold chemotherapy should include the indication, what cancer type they have, what is the aim of treatment, and whether these patients are in deep remission or not. So take-home messages, cancer care and COVID treatment does collide. You should be very careful if a patient is COVID positive. Your plan should involve good communication with the patients. There should be good resolve between the healthcare workers and the patients and the attendants. Your treatment choice should be based on the individualized risk of the patients. You should raise and reorganize healthcare system as we did with our telemedicine and research. You have to look at your own data, whether our outcome is the same as others as well. Hence, we can follow their recommendations. And what we have learned today will be very useful in terms of what we do in future. With this, I'm going to end, and I thank you for your attention. These are some of the resources which you can use for further information, and thank you once again.
Thank you, Dr. Adnan. We can take some questions that we
Sure.
had here, okay? So let's start with the first. Does a history of cancer raise the risk for health complications from COVID-19?
So we did see that according to the Wuhan's data that patients who had malignancy did have a higher risk of complications when you had malignancies. There was another article that I was recently looking at was certain malignancies had a higher risk, like in patients with lung cancer and patients with lymphoma. So what I just showed you in UK trial, there was none, but more data is coming in where we are talking about certain malignancies like lymphoma can have higher complications, and also because, again, lung is already compromised in it, and lymphoma as well.
Okay, so I'm going to combine two questions because they're almost similar. Is COVID related with development of cancer by any means? And the same kind of question is there a direct or indirect relation of COVID with development of cancer?
So I don't think this is too early to tell whether COVID does cause cancer. Most likely there will not be any correlation. We so far know that patients who have malignancies have equal risk in terms of developing COVID. It's the other way around. However, your complication risk goes up. So COVID infection does not cause malignancies. We do not know that. It may cause lung complications, long-term effect. That is too early for us to say that people who survived from COVID and had any lung complications, whether they develop something later on, time will tell.
Okay, prior to chemotherapy, when should a patient get tested for COVID?
So right now, anyone who was starting treatment for their disease where there was high risk of developing immunocompromised state, we at AKU were testing our patients. You always have to keep in mind that it's a costly test. And we at outside they were, when I say outside in international, rich countries, they were testing before every cycle. This is something that we do not recommend for our setup because of cost. Also, patients who are on chemotherapeutic agents, which is not going to compromise their immunity, you can bypass them. But someone who is going to get treatment for leukemia, for lymphomas, someone who's going to get 5 days of IE, I would certainly recommend to get them tested before starting. And if they are asymptomatic and they're doing fine, then no need to test them. If they develop symptoms which are concerning for COVID, then you should test them again.
So the next question is, where should a cancer patient undergo self-isolation? Is it necessary to be in the hospital, or home self-isolation is good enough?
If you are asymptomatic, home self-isolation is perfectly fine. I think education is the key. Having close contact with your primary care is important, even if it is telehealth. For the longest time, patients did not believe in having a communication with their physician on telephone. So I think the key is how symptomatic are you, knowing the signs at which you should seek out help and reach out for more acute care. It was okay for our patients who were asymptomatic on treatment to be self-isolated at home and they recovered fine. But any patient who was getting more symptomatic in terms of shortness of breath, the fever, so we called them in. As you can see, 60% of our patients did come in because, again, we didn't know what to and how to manage these patients. So we had a low threshold on calling them in and admitting them. But at the end of the day, if the symptoms are fine, you can home isolate them.
Okay, so I will take two more questions and then we will ask the next
Sure.
speaker to come in. The second last question is, what is the trend outside Pakistan? So you see a patient in clinic and you suspect it's COVID. What is the channel to follow? Where do they go for their testing?
So again, in US, it was very different. They were doing at home testing as well. They had centers where patients would go, or they can go to their primary hospital like us. They would go to the tertiary care center and get themselves tested over there. So any patient who was on treatment and suspected to be, if they were asymptomatic, their centers, like I was looking at MD Anderson data, they were testing them either way, at home or they were calling them within their centers. The key is whether the patient is symptomatic or asymptomatic, patient how critical is in terms of their shortness of breath.
Okay, so last question. This is specifically for breast CA. The participant is asking whether patients with breast CA need to get tested for COVID prior to chemo, and will cancer treatment for breast CA will deteriorate COVID or not?
So we just saw the data according to UK registry that people who have received chemotherapy, there is no increased risk in mortality due to treatment. So it is okay, but at the same time, if your physician can modify your treatment, say for instance, someone who is getting dose dense, where patients are getting treatment every 2 weeks, one can change that to every 3 weeks without having any effect on your outcome. So modifying your treatment is the key. Now the question where you ask whether you should get tested before chemotherapy, it all depends whether you are getting treatment for the first time or you're already within getting treatment. There were a lot of centers outside AKU who were not testing their patients before starting chemotherapy, and they did fine as well. I think communicate with your physician if you have any symptoms that are suspected of COVID. Or if you have exposure to someone who has COVID, I would say then I would have a low threshold. Right now, we have not changed our policy, but I think very soon we will be sitting down and putting our heads together to see whether we should be testing all patients before starting their first chemotherapy. We are not testing anyone in between unless they're symptomatic.
Thank you very much, Dr. Adnan, for this, and thank you for taking the time out. Thank you.
Thank you very much.